And I did want to start by saying, so I am a PA. I have been a PA for 25 years, and I have spent most of my years working in emergency medicine, but also I actually have a dual appointment right now in emergency medicine and addiction psychiatry. And I have spent some years also working in family practice. And I'm somewhat obsessed with with removing every barrier to addiction treatment. So I figured out that the emergency department was a really great place to engage and offer treatment to people who may have trouble figuring out how to enter our system of care, and then realized how many barriers there were. And so helped initiate clinics, just a clinic across the street from our hospital, which is family practice based. I also initiated a clinic in a very rural part of our county. And I say county, I'm up in Placerville, and so in El Dorado County. And all of that was really meaningful work, some of the most meaningful work I've ever done in medicine. And I now work in Sacramento County and again have that dual appointment. So thank you for having me today. So I am one of the co-founders and principal investigators, senior directors of Bridge. And so Bridge, hopefully people have heard of it. We've been doing a lot of work in California for the last 6 or 7 years, and we're a program of the Public Health Institute. I have no disclosures other than I am one of the senior directors and PIs of Bridge. So where I want to start is, and I had no idea. I think we often think of our workplace, it's like we know who makes it into whatever setting we work in. And I've had the honor of working in different settings and realize there's different groups of people. But I recognize that over 46 million Americans have a substance use disorder. And when somebody asked me to start a program to initiate treatment for opioid use disorder in my emergency department, I said, well, I don't think we have that much opioid use disorder. I don't see that much opioid use disorder in my facility. I see some overdoses, but people don't come in for opioid use disorder. And what I realized is there's people who are invisible in our communities who have not had access to care. And so in this number are of course women, and in this number of people are pregnant women who I realized were vulnerable in my county because we did not provide a safe place for them to seek treatment. Now, this is also very important. This is from SAMHSA, that 95% of people not receiving treatment, thought didn't want treatment or didn't think they needed it. And so I liken this to other prevalent medical conditions. Like, what if 95% of people with hypertension or diabetes or asthma or COPD were not receiving any treatment and didn't think they wanted it or needed it? And so I think like that all the time because I think, well, how we would think really deeply about how to make this accessible to them. We think about different groups of people and why they may not be accessing treatment, why they don't want it, why they don't feel like they need it. And often that comes back to us in making it accessible, making sure I call it priming, is like talking to people about it to tell them what we should be doing, what is what works, what treatments are out there, and we can really change the narrative and we can change people's thoughts and feelings about like medications for opioid use disorder by simply having these discussions in real time with people. So that's what we need to do. We need to reimagine care that people want. We need to go where people are at, and we need to have these conversations, and we need to share common messaging. When somebody has hypertension and we determine that they need medications, it's really widely known that medications work and people may need them, and that this can prolong their quality of life and the number of years they live. So these are the discussions we should be having on a regular basis and feel comfortable having these discussions with our patients. And it takes an entire community. I can tell you that not everybody receives their information from me. People often receive information from their family members or from other community organizations. So it really matters in where we share this information. I can tell you I've realized so many blind spots. I stay very humble in this work and realize I often see what I see, but realize that our Women's and Children's Center needed this information. So we have done presentations there that, really thinking about vulnerable populations in our own communities, and then making sure we're communicating information. So what is the information we communicate? So in California, we have built this entire system through emergency departments because when myself and our other co-founders were thinking about how to save lives, and really, I'm very proud of the conversations that we had. How do we make a difference in communities right now? How do we keep people from dying from overdoses? 42% of Americans know somebody personally who has died from an overdose, right? This is really prevalent. So, how do we remove all the barriers to treatment? And what I often ask is when you think a family member calls you and says, I'm struggling with opioids, I've been buying pills or using fentanyl on the street, what comes to mind for you of best treatment pathway? And I can tell you for myself, it wasn't based in medical care. And there are treatment communities that do amazing work, but we have to work together with medications that are proven to save lives and with all of the other treatment providers out there. We all need to come together to make a big difference for people and to create a shared understanding of what treatment is out there. So we have tried to remove all of these barriers, and we really leveraged emergency departments because it's a site of care for people who are not often engaged in a system, who don't have a primary care physician, who aren't able to make a timed appointment Monday through Friday, 9 to 5. So we think of this low barrier treatment, offering it in the lowest barrier setting you can possibly provide it. And in addition to that, knowing what resources are in the community, like knowing my Women's and Children's Center is doing a lot of this important work, making sure that they are aware that we can initiate treatment in emergency departments, making sure they have information on substance use navigators. So we really want to connect to care and community. And then we want to promote a culture of harm reduction, which is why I started out in medicine, is to reduce harm, save lives, keep people living their best, healthiest, life. And so really continuing that through this work in terms of how we address substance use disorder. Now, I can tell you, when you look at this map, we did lead at California Bridge the largest and fastest expansion of emergency department-based medication for addiction treatment in the country. And you can all feel very proud of that, because in San Diego, some of our original champions who have done amazing work are right there. And the idea is that you can see an H on the freeway for hospital, and know that just as if you were experiencing chest pain, that you could go to that hospital and expect to receive high quality evidence-based care for opioid withdrawal or for a substance use disorder. And that's really what we should all expect. It should be that if your family member calls and you have this small window where you haven't heard from them in a while and they reached out and said they need help, that you know where to go, that you could go to an emergency department and initiate treatment, that you could then continue care. Like, I'm very protective of that experience with my own family. So you think of what you'd want that to look like. And that's really what we've been trying to do across California, is create the kind of system that our family and friends would want to access. And then we've taken it even further. So we have our California program, of course, where we are continuing to figure out ways to make this easy, make the right thing to do easy. And so we have funding right now where we're working on developing connections to care, regional communities of care, so we can again make it so that people can get access right now and get the kind of access to treatment that is evidence-based, and that promotes, that really treats them as an individual. So if they needed residential treatment, they could get it. If they needed, if they wanted to start medication at home, they can do that. It's really individualized but evidence-based care, and making sure that's integrated into all of it. We are doing an EMS program. We have EMS across California. I think at least 30% of EMS of counties across California now have an EMS bridge program where they're starting buprenorphine in the field. And then we have a national expansion project, which I'm leading, where we've done work in every single state, but deeper work in 17 states to dig into what we've learned in California and make it work for other states. But at the same time, we've realized there's opportunity, and very similar communities where we can do a lot of screening for syphilis, HIV, Hep C, and initiate treatment, connect people to care through emergency departments, that we can have population level effects when we do this, like a public health screening program through emergency departments. And that's funded by our California Department of Public Health. And then we have Access Bridge. We've also realized specifically that many women don't have access to reproductive care. And we can do a better job with managing miscarriages. We can do a better job in women's health in particular. So we have Access Bridge, which is working not only in California, but across the country, and particularly in states where there may be a lack of OBGYNs available, where simply We can provide birth control. I know it sounds crazy, but for 25 years in emergency medicine, that wasn't routine. And now we can do some screening to see if we can provide this kind of care and access to it. So it's become a program where we've become pretty good at getting things done in emergency departments and just recognizing the effect that we can have when we give this open access to care. So I am also going to say that, very specifically, more pregnant patients died from overdose than from many of these really these life-threatening pregnancy complications. So this is important. So addressing opioid use disorder for our pregnant patients is really important. And often women are not seeking treatment or are delaying treatment because I meet so many women who tell me that they don't they're starting tomorrow. Like, I'm going to start treatment tomorrow because they don't want anybody to know that they have an opioid use disorder. They're afraid to go into a medical setting because of the potential consequences of that, to be labeled, to have a fear of losing their baby, of having CPS involved. There's many different levels where it's very complicated. And yet I meet so many pregnant patients who are just desperate for treatment. They've so badly want it. I had a patient once who was coming in. She's in her third trimester of pregnancy, and she was coming into me to get treatment, and the motorcycle that she was on broke down, and she walked 3 miles to get treatment. And when she showed up, I stayed late. I was told, "Hey, your last patient is late." And I had some dinner thing I was going to go to, but I thought, you know what, I'll wait. That's fine. I'll wait. And I'm so grateful I did, because she came in and she had her motorcycle helmet. And I said, "Were you on a motorcycle?" And then she told me the whole story. And I thought, this was an opportunity, that was so important that she walked 3 miles in to get treatment. So many of the women that I'm talking to are just so desperate for treatment, and we need to make it easy for them to get it. And this talks about 4 in 5 pregnancy-related deaths in US are preventable. All overdose deaths are preventable. And then when we look at all overdose events, and then we look, these are pregnancy-related overdose deaths per 100,000 person days. When we look at all deaths, and then we look at how, when people are not on medications, there's this much higher rate of overdose death. And then we know that when people are on medications, that we reduce their chance of death, their risk of death. So this is really important to dig into. And so this is why, medications for opioid use disorder are really gold standard treatment in pregnancy for somebody with an opioid use disorder. And we need to strongly advocate for it and make it very easy and accessible. And I also need to recognize that the emergency department is the only option when pregnancy emergencies happen. Luckily, we have OBGYNs on call most of the time. We have emergency ultrasounds. We have ability to stabilize pregnancy emergencies. So digging into that and having all things available to pregnant women and doing it in a way that frees of judgment, where we are saying, "Wow, I'm so grateful you're here. We're going to take really good care of you," and individualize their treatment and make sure that all of their needs are addressed. So I'm going to give a little word on buprenorphine. Buprenorphine is what we have. I give both methadone and buprenorphine from my emergency department, and it's whatever works for patients. But I'm in this setting, I'm going to talk a little bit about buprenorphine because often people have less familiarity with it. So buprenorphine is what we consider a partial opioid agonist. And it's as compared to full agonist. Full agonist, I always said, does all the things. So fentanyl, hydromorphone, oxycodone, hydrocodone, morphine, those are all full opioid agonists. Buprenorphine is unique, and it's considered a partial opioid agonist. And it comes in these sublingual, these tablets and films that can dissolve in the mouth. And it can be given, even also, we have long-acting injectables, we have patches, we have different ways that buprenorphine can be given to patients. And the reason I show this as often as I can is the reason that we like buprenorphine so much is because it has a ceiling effect on respiratory depression. So people die from opioid overdoses when they stop breathing. And so yet when we treat them with buprenorphine, it creates a ceiling effect on respiratory depression and sedation. So it doesn't make them, quite as sleepy, while blocking all of the other opioids. And that's really, really important because we can give a medication that keeps them breathing and that blocks the other opioids. Now, if it's given to somebody who's actively taking an opioid or has opioids in their, that are working in their system, it can also bump off those opioids. So if you hear somebody saying that they want to start it, but they have to go into withdrawal first, that is true. And when we talk about pregnant patients, that can be really challenging because, especially in their third trimester, that can involve vomiting, that can make them, put them in a lot of pain and, could increase their risk of preterm delivery. So we have to take it really seriously. And I often offer admission to patients who want to start buprenorphine, especially when they come into my emergency department, because it's so important for them to get on it, right? It reduces their risk of dying. And there's a lot of studies that show how much it increases their ability to do all of the other things in their life. So this is a really important moment when somebody seeks treatment. And so I will often offer admission to do it in a way that where we can cross over the buprenorphine medication so they don't have to go into as much withdrawal. The other reason we like buprenorphine is it lasts a while, 24 to 36 hours. All right, so when we're talking about substance use disorders and pregnancy, specifically opioid use disorder, we want to make sure it's a medication first mentality. We don't want to make our pregnant patients jump through a ton of hoops to get to this medication that is life-saving. So we consider what we do a lot in California is we always say medication first. So we don't need to wait on urine or get a urine drug screen. We don't need to get a ton of labs. We really want to make sure we get access to this medication really quickly. So I also want to recognize that the postpartum period for women, really high risk for depression, return to use, overdose. There's some myths out there about medications for mood is medications for opioid use disorder. So this is, I can tell you, we have done a lot of work within our OB unit in our hospital to ensure that we have navigator who it really like first priority is our pregnant patients, patients who are postpartum. We really want to make sure that they have access to medications, and we very much protect this period. We want to make sure people have transition to ongoing care, feel welcome, don't feel judged, and that they also can tell us what kind of dose they need. Are they still in withdrawal? Are they craving? So we also want to make sure that we talk about contraception. This is one whole person that we want to make sure that in this postpartum period that we support. And I did want to also mention that when we start, one of your questions may be, but is buprenorphine safe in pregnancy? And the answer is yes. Both methadone and buprenorphine are safe in pregnancy. And what we found with buprenorphine, and so I offer both to my pregnant patients, and I also know that with buprenorphine, there's a less of a hospital stay. There's less duration of something called neonatal abstinence syndrome. That's where a neonate may experience some withdrawal symptoms, and that with buprenorphine, there's less of a total dose of morphine given to the baby. So then this is something we're really trying to get away from. Our babies, so there's this myth that babies exposed to drugs in the womb are addicted at birth. And so this is a fact. Newborns cannot be addicted because it involves compulsive behavior, which our newborns do not engage in. So I just want to also talk about this when we say like how we can talk about this, especially because this can increase a woman's, like how somebody feels about themselves as well, is we want to engage people in treatment and just note that babies exposed to drugs in utero may experience withdrawal symptoms, and that can be managed with medical care. That babies recover and they thrive with support, and we also want to provide this really supportive care that's non-judgmental, so that we can engage people in and allow people to self-disclose a substance use disorder as well, knowing how important it is for family health. And we also want to, it's been exaggerated that there's this severe permanent damage from in utero drug exposure. There's other factors like poverty, lack of prenatal care. So we do know some things. Of course, stimulants can impact high blood pressure, can cause lower birth weight. We also know that they may have limited newborn related withdrawal syndromes. Only alcohol is a specific syndrome, the fetal alcohol spectrum disorders. But there's a lot of complexity here. So we want to make sure we support and engage women and access, we want to make sure that they have access to healthcare, family support to decrease some of these social determinants of health. And what we do know is that most babies who have been exposed to drugs in utero do not exhibit severe or any lasting impairments. And the other thing I wanted to talk about is that breastfeeding is strongly recommended, full stop. So medication for opioid use disorder is safe in breastfeeding. Now, other unrelated drugs, we need to talk to our nursing moms about in terms of, in form of risk, shared decision making, careful monitoring. If somebody is struggling and using drugs, pump and dump. But what we definitely want to do is have the conversation. I can't tell you how many women I have talked to about drug use who said that I was the first medical provider they could ever talk to about this because they felt so judged and felt like they were going to be treated poorly by somebody if they disclosed this. And just having the ability to have this conversation is extremely important, and having a realistic conversation, not just writing and discharge paperwork, stop using drugs. That just doesn't help people. It's having a realistic conversation with people. So we want to make sure, again, we provide access to medications. We want to make sure we provide naloxone, easy access to naloxone. There's a lot of different harm reduction techniques that we can use to decrease infectious disease, to make sure that we consider a person a whole person. Housing first. What kind of, are they going to be able to get this medication at a pharmacy? Have we made sure that they have connection to ongoing care? And community? Community is really important. So when we're keeping parents alive, we want everybody to know buprenorphine is the queen here. We want to make sure that we provide access to buprenorphine. We want to remove barriers to treatment. We don't want to engage in universal urine tox screening, and we want to make sure that parents have access to medications for addiction treatment throughout and beyond their pregnancy. So what we do want to do, and when I say universal substance use disorder screening, for me, what that looks like is safety in disclosure. Provide a program that your family member would want to engage in without judgment, that people would feel safe disclosing a very highly stigmatized condition. We've had a big impact in the state of California, so more than 400,000 people. This is much higher now. We just don't collect the numbers anymore, but this is in a pretty short period of time that we were able to have a massive impact in California. We identified through emergency departments more than 300,000 people with opioid use disorder. We have given a ton of buprenorphine out, more than 126,000 prescriptions for buprenorphine, even more than that. We've started a lot of people on methadone. We just don't track that as much. And if you want to talk about getting naloxone out there, emergency departments can do that. This is a recent article that was published in JAMA, where when you look, I hear so often people say, "But I can't do that. That's hard. I don't understand buprenorphine." I'm just here to tell you you can. We did this in short order. This was just published in JAMA, and 2017 is when I started my program and got together with a few others who were doing this, and we started talking about what to do. In 2018, we started getting some docs involved in emergency departments, but we got funding in 2019 to fund hospitals. And look what happened is a lot of unique patients with a prescription from an emergency clinician, new patients with the first prescription ever from an emergency clinician. And look at the amount of unique emergency clinicians who started prescribing. So what I can tell you is that this works. People can learn, people can get this medication. And when we do that, it makes a big difference. Well, the other thing I want to mention is I talked in the beginning about what we do for COPD or other medical problems. This is really interesting to dig into. I don't have enough time to really dig into this here, but this is also from our JAMA article. And the bottom line here is when a prescription is given from an emergency department for buprenorphine as a first start, 1 in 9 people then remains in continuous uninterrupted treatment for 6 months. And that's a really big deal because I start people on all sorts of treatments for a lot of different high-risk medical conditions. And often there's an interruption in treatment and somebody comes back to the ER for a refill of their blood pressure medication or their diabetes medication. So we have the opportunity here to start a medication that 1 in 9 stays in uninterrupted treatment and follows up. And actually a third remain in treatment, but sometimes we have to give a second prescription. So this works. This works and it's life-saving treatment. We want people to feel good about it and tell people about it so we can make it safe for people to disclose this to us. This is my navigator on the left. We put signs, I wear pins to engage people in treatment. And we've had this national reach. Every state we've been able to at least talk to somebody in and then do deeper work in 17 states. We have a ton of resources, including a pregnancy initiation guide. We're actually updating that right now, so TBD. But we'll be releasing some updated guidance as well and increased resources for our pregnant patients. We also have information on Access Bridge, which is a program that we're doing to improve reproductive care for women. So that is it. We have lots of learning opportunities that are free. So I appreciate the opportunity to share this with all of you today. Thank you.
Thank you, Arianna. What a great presentation and incredibly informative. So I'm going to go ahead, before we take question and answers, I'm going to go ahead and introduce Dr. Heinrici and have her do her presentation, and then collectively we'll do question and answers at the end. So thank you. Perfect. It's up and running. Looks good. Thank you.
Good. Can everyone hear me?
Yes.
Great. Okay. It's so nice to meet everyone. I'm Aleka Heinrici. I am a family medicine doctor and addiction medicine doctor. And a little bit more about my background. Let's see. I am, oh, it didn't advance the slide, did it? Let's see.
You're struggling advancing the slides?
Yeah, I don't think it advanced the slides. Let me just stop my share real quick and then share again. And I want this one. Okay. So my background, I have been SUD field adjacent since the early 2000s. I worked in detox, street outreach, syringe exchange back up in Portland, Oregon. And I've been practicing addiction medicine since about 2012. So I'm primarily a family medicine doctor, but I kind of jumped into addiction medicine early on in my medical training. And I have a pretty broad background of working in a lot of different settings. So obviously the harm reduction early on, and then I've worked in hospital settings, outpatient, residential treatment, detox, etc. I also have lived experience, which definitely informs the way that I approach my practice. I want to start by telling a story. It's not my story, but it's, and I'm going to go into some detail on it, but I think it's really important because I'm going to be talking about some of the local ways that women interface with different communities and community services here in San Diego. And I thought that this story would be a good way to highlight some the importance of the work we can do. So Amanda was a patient that came to me in 2019. She was born in Florida. Her parents both struggled with addiction to opioid pills, and she grew up with poverty. She had childhood trauma. She started using pills at the age of 13. It was readily available. And she was able, though, to go on to get a GED and get a job in customer service. Around 19, she met a man that did not use substances, and she was able to stop using and got married and started having kids. And so he was kind of her lifeline to like not using substances. She was very much in love with this person. Unfortunately, there was inter-partner violence and abuse, and she ended up leaving him after staying off of all substances for 7 years and having 3 kids. When she divorced him, she came out to California at the urging of a friend. A friend said, come on out with your kids, you know, you can start anew. So at 27 years old, she came to San Diego, and this is 2018. Shortly after getting to San Diego, she ended up relapsing and beginning to use opioids again, and her addiction progressed very quickly. She was incarcerated shortly after, and in incarceration, she actually gave birth to her 4th child. She got out of incarceration and was released to a residential treatment center with her newborn infant and her other children. And she met me after she'd gotten to the residential treatment center, and was having severe cravings for opioids. And this was back, remember, this is 2019. We weren't doing as much medication for opioid use disorder in our correctional facilities back then. So I met her, put her on buprenorphine. She was doing very well. She felt much better. Was really scared. She told me, I feel like I'm going to leave and use if I can't get help. So she graduated residential treatment center and moved on to outpatient. And unfortunately, we could not find a sober living that would accept her and her 4 kids. Finally, there was a faith-based house where they accepted her. And it was not ideal because she was required to do like 2 hours of Bible study a day, which is very hard when you're managing doctor's appointments for your special needs kid and getting the other kids to school. And then she was trying to find a job. So it was very challenging. And after a few months, she also was complaining of cockroaches and mice infestation. And so she put in a complaint, and after she put in the complaint, she was given a 30-day notice. She was an excellent mother. She would bring her kids into the clinic if they weren't in school, and the younger ones, and really that was like her biggest purpose in life. When she got the 30-day notice, I saw her, and it was January of 2020. And she said, I got to go somewhere. And a friend of mine offered me a place to stay, but it's out of town and it's rural, but I'm going to go. And I was nervous because she had done so well. She was doing so well. And this is obviously before the pandemic. We weren't offering any telemedicine. So when she went, I knew that was it, right? I wasn't going to be able to contact her anymore. And we got online, we looked at providers, where she was going. We did one last try of trying to find any housing resources. And I didn't hear anything from her until 6 months later. I got a letter from a coroner's office in a different part of California that said that she had died of likely drug overdose, and they were wanting some information to know if she had struggled with substance use. I still get choked up over that case, sorry. So, we're going to talk about women with substance use disorders and the barriers to care, the specific challenges for women in San Diego, and some areas for improvement and growth. There are some physiological differences. So with women with substance use disorders. So a good example of this is lower stomach enzymes can lead to women having higher blood alcohol levels for the same quantity of alcohol drinking, and they can also develop cirrhosis quicker. I use a lot of acronyms. I'm really sorry. I know we have a broad audience, so I will say them out, but I don't always spell them out in my PowerPoints. Women also have a very complex reproductive health life, the menstruation, menopause, hormonal changes, and the events of pregnancy and miscarriage that can and do happen to many women. We know that most people with substance use, that co-occurring mental health is really common. So 40% of individuals with substance use disorder also have mental health disorders. Women tend to have the highest rates of trauma compared to other parts of the population. Anytime you see a little star, that is referring back to Amanda's story. So these are places that her story really exemplifies these things. Women are more likely to experience anxiety, depression, and PTSD, and we know there's a connection between substance use and intimate partner violence. The graph on the bottom is actually local data. So just if you look on the left, it's looking at the ACE score. I think a lot of folks in San Diego do know what the ACE score is. It's the adverse childhood events. And you can see we've got female and male, and the women have higher scores of, so blue is a score of 1 to 3, and orange is a score of 4 above. And so women have a higher frequency of having these higher scores, which leads to a whole host of other complications, higher risk of comorbid physical health diseases, as well as substance use disorder. Many women are also the primary caregivers for children or elderly parents. They're more likely to have gaps in their employment, which can lead to financial strains due to the fact that they're caring for others. And there's just other barriers that affect women more so than men. So there is increased stigma and social judgment. This is infused by our cultural view of women, motherhood, gender roles, and it's very, very, very strong. There's also the issue of pregnancy, which is pregnant women with substance use disorder is the most highly stigmatized subgroup. They experience barriers to care exponentially. Fear, and this was discussed earlier. So fear of loss of custody prevents people from seeking treatment, just their own internal shame and guilt, lack of support for single mothers in all phases of treatment and recovery, and because of that, or one of the causes of that is that we know that women are not accessing care, and as we saw on a slide earlier, one of the highest periods for risk of opioid overdose is at 7 to 12 months postpartum. So this has real consequences for risk of death. There's also limited gender-specific treatment options that adequately address the issues of PTSD, trauma, sexual trafficking, interpartner violence. In terms of local trends, so this is a busy slide, but just to kind of, I want to let everyone know what I've been seeing in my practice. So first of all, we've had the change of the source of meth being from domestic labs to imported. We've seen increase in purity and potency. We've seen lower costs, more availability, higher incidence of complications with this newer form of meth. So meth-induced psychosis, overramping, heart disease, overdose. We also have the 2020 fentanyl wave that was very intense in San Diego. I went from about 90% of my opioid use disorder patients having using heroin, about 5% using prescription narcotics, and 5% using fentanyl. By the end of 2020, it was about 95% using fentanyl. So it happened very quickly. We saw the contamination of cocaine and meth. And in our clinic, we actually saw this convergence of use. So folks that had previously primarily used meth were now using fentanyl because they started out using contaminated meth and then started using fentanyl as well. And conversely, we saw people that had just been using heroin switch to fentanyl and then start adding meth into their daily repertoire. We also saw Mexican Xanax, right? So less Xanax being prescribed, alprazolam, and then the bars, the Xanax bars, which is the most popular form people take their Xanax, produced in large quantities and coming over the border. We saw widening racial ethnic disparity in overdose and treatment access, and an increase in fatal and non-fatal overdoses in adolescents. So that's kind of what we've seen in the last few years in San Diego. In terms of substance use in women in San Diego specifically, in San Diego, the statistics really mirror that of the nation. There's overall lower rates of substance use disorder per 100,000 people in females compared to men, although there are some parts of the county where benzo use in women is higher. And there's a higher burden of mood disorders, adjustment disorders, and PTSD, which again mirrors that of the nation, and a higher impact on marginalized communities. So lower treatment rates and accessibility for Black and American Indian women. I wanted to just show the makeup of our clinic. So we're a large, fairly qualified health center. We have about 20 clinics. We serve folks all the way from San Ysidro to Campbell to Julian to Escondido. So pretty broad geographic area, and majority Medi-Cal under and uninsured patients. In 2024, we saw 1,292 patients in our SUD department, and it was about 1/3 women, 2/3 men. And on the bottom is the distribution of the specific diagnoses. Obviously, many people have one or more of these combined. So, but I just separated them out, and this it reflects mostly that of the nation as well. We do see actually in our population, women 3% benzodiazepine and men 5.3, but in other parts of the county, the benzo use in women is higher. So. Challenges for women's SUDS in San Diego. We're going to talk about some specific challenges that I've seen folks face. The housing crisis and its impact, childcare and recovery support that's needed for women with children specifically, pregnancy and substance use disorder, and then how women are navigating criminal justice and child welfare services involvement. So we all know that we live in one of the most expensive parts of the country in terms of housing. It's a big deal. This limit of access to safe and stable housing really affects women at all stages while they're using, and if they stop using and are seeking treatment or recovery. This can lead to survival sex. So folks engaging in intercourse in order to feel like they can have a safe place to rest their head or a roof over their head. It also means that people stay in unsafe relationships due to fear of homelessness. It means that they may be unable to find a safe and sober environment. And sometimes it leads to them moving out of the area for housing, sacrificing healthcare and other support. Again, back to Amanda's story. Uh, Recently, for those of you that are working in the field here in San Diego, we've seen a lot of county outpatient SUD programs that offer sober living. They run out of funding, and people will get kicked out of their sober livings overnight, and that's a really big deal. Usually it's not overnight. Usually they have like a week or two of notice, but it's something that's continuously going on and affecting patients, people. Solutions. I wish this was a longer slide. Unfortunately, I cannot offer a ton of solutions on the housing crisis. It's a very complicated problem. But I do want to say that other than advocating for this in our city and in our community, I wanted to just make a note about the housing first model and other types of housing. So when I was in Oregon, there's a program called Central City Concern. And what I noticed there is that they have a lot of single occupancy units, and they had different programs for different people. So they had folks that were engaging in like an intensive outpatient program called the Mentor Program. And those units required you to be completely off of alcohol and drugs, do urine drug screening and go to meetings and et cetera. And that worked very well. If someone used, they would get kicked out, right, which is controversial. But there were other housing options that they could then go to that didn't have those same stringent requirements. So if someone had severe mental illness or just wanted more of a harm reduction approach, there were other housing units that they could then apply for. That was very different from San Francisco, where I did my residency. So during my residency, we had to do home visits for our patients in SROs, single room occupancy, in the Tenderloin. And I don't know if any of you have been to the Tenderloin, but I can tell you, I would go do home visits and literally be walking through clouds of crack cocaine smoke and seeing people injecting in the hallway of my patient's housing. And so in San Francisco, it's housing first, which is good. We know that's evidence-based, right? Like we need to get people housed and off the streets. I'm a really big supporter of having a variety of options and letting people decide, like say, hey, you know what? Like I actually really want a sober, drug-free environment, if that's what's right where they're at. And then also having different types of housing for different people, depending on where they're at in their life. Women with children, obviously, with that comes a whole other host of barriers. And in San Diego, in particular, the gaps that I've seen is women that have multiple children or older age children. Again, back to Amanda's story. So women that have teenage age children or that have multiple children have exponentially harder time getting housed. There's also a lack of support services with balancing childcare, going back to work, getting an education, etc. So really just a need to increase services in the area of sober living environments, jobs and childcare programs, long-term housing, and then this idea for continuity care or integrated longitudinal services where women are getting their medications for addiction, whether it's for alcohol, whether it's for opioids, they're getting mental health, they're getting reproductive health, and they're getting physical health. And that's ongoing and hopefully integrated. So we've come a really long way in this. All of the federally qualified health centers have done excellent. And it's been really cool to see. They've all really, you know, been stepping up to offer substance use disorder treatment and then finding ways to integrate that into the rest of the federally qualified healthcare services. So I think in our community clinics, we've come a really long way. There's just some linkages that are still not happening. So in terms of pregnancy, labor, and delivery, there's definitely some challenges that we have. There is still lack of screening for substance use disorder in early pregnancy in a lot of the different settings where women are seeking care or just going for routine prenatal care. Another challenge is the policies and procedures that we have around urine drug screening. And I don't know if there's anyone here that works in the hospital setting, but this is a big issue. So we have problematic policies and procedures in a lot of the hospitals. A lot of the hospitals, right, the women won't get screened early on in pregnancy. They'll come into the hospital in labor and it's just random urine drug screen. And the random urine drug screening is done based on a nurse, you know, if they think that there's a chance that the patient is using substances. We know that that approach is inherently prone to have bias. And I had a resident that worked with me that actually looked into one of our local hospitals and saw the same statistics and the same in our local hospitals that Black and Indigenous women or women of color were unfairly targeted with random urine drug screens and more likely to have the consequences of that. So just, you know, we're not screening everyone in the same way, which is problematic. Many of the hospital policies then, once that test is done and it's positive, it reflexively causes a referral to social work, and the social worker will meet with the pregnant person or the laboring person, or you know, they're now postpartum, and will refer to CWS. Now, this is very problematic because oftentimes the physicians are not actually involved in this process. And these are what we call ELISA immunoassay tests, which means that there can be false positives. And unfortunately, I've seen some really devastating outcomes. I've seen women have their children removed from their care for what later turned out to be a false positive test. And it's not as easy as just, oh, whoops, oh, sorry about that. Well, here's the baby back. No, it took her 2 months to get her baby back in her care. I've seen women that received fentanyl in the labor. The test was done afterwards, and then the baby was placed on their abstinence. So when they basically said, okay, this baby's in opioid withdrawal, so they put the baby on the protocol. And I stepped in and said, oh, wait, she's actually been on buprenorphine the entire pregnancy, and she has tested negative for all other substances the entire pregnancy. And the CWS worker, actually, I think I have this case another slide, well, said, well, do you mean to tell me that doctors would prescribe a medication that can cause withdrawal symptoms in an infant? And it was a really striking moment for me because it made me realize how folks that are working with women that may be pregnant or maybe postpartum with substance use disorder really just don't have all the information that absolutely, yes, buprenorphine is gold standard evidence-based treatment that is life-saving for mom and baby. So we have a lot of work to do in that area. And there's folks that are working on this, and I'm hoping that it's something that we can see improved. Another challenge is that OB providers may or may not provide medications for opioid use disorder. And if they do, it's limited sometimes in how long the services are provided in the postpartum period. That is very important because women, after they have a baby, they might not go back and see their OB that much. And if it's not at like an ongoing SUD clinic or place where they're getting where they know they can go for their medications, then they might stop taking them. And we know that the highest period of chance for overdose is that 7 to 12 months. So that can be deadly. And then stigma. It's especially prevalent in spaces for care for pregnant people. As I mentioned before, most highly stigmatized group of folks. So really, really impactful. I love this slide, and I actually do want to just like read through some of them because I think it's I've seen all of these in San Diego in my practice. So there's different levels of stigma. The individual stigma we've talked about, a newly person pregnant believes they're a bad person because they're using substances and they delay seeking prenatal care. I'm going to skip the interpersonal one. We'll go on to organizational. A healthcare institution obtains a urine drug screen in a newly pregnant person without consent. They respond to the positive result by involving CWS, but cannot provide such services. As a result, the pregnant person loses trust in their new medical provider and is lost to further perinatal care. At the community level, a substance use treatment facility does not offer a pregnant person evidence-based medications for substance use disorder. Prior to drug Medi-Cal and having these facilities contract with the county, we saw this all the time. Women were not allowed to take buprenorphine or methadone or any other evidence-based medication for their substance use disorder. This changed in 2018, right? I mean, I think most people in this group know we had drug Medi-Cal, and most of our Medi-Cal patients, anyways, people that are Medicaid, are getting services in certified DMC centers where they will lose their contract if they deny someone access to that evidence-based care. Oh, it's been wonderful. And I've seen a lot of these programs come around to understanding why it's so important to provide evidence-based care. And it's been really great to see. But this still happens, and it happens. It can't happen in the DMC programs because they'll lose their contract, but it does still happen out in the community all the time. And then public policy. So criminalization of substance use and involvement in CWS in pregnancy can decrease someone's engagement in medical care, which then increases their morbidity and mortality for the parent and the child. So it doesn't have, you know, it ends up sometimes not having the outcome that folks think that they're going to get by enforcing some of the practices. So pregnancy, labor, and delivery in terms of solutions, definitely a big advocate for universal screening early on if someone's seeking prenatal care, and then referring them for further assessment and treatment options if that's what they're seeking. So this is really important. This is how we prevent that kind of like someone coming in, you know, 8 centimeters dilated and having had them not getting services that whole time. The important thing to know about this is that when we do this, then we're not judging them. We're not adding to their shame and guilt. We're offering them support and compassion and services. There's also a need for better collaboration and connection. So an example for that would be labor and delivery social workers really being connected to the perinatal programs. I have sat down with a lead social work at one of the local hospitals who works in labor delivery, and they could not name a single perinatal program. Not one, not outpatient, not residential. And we have really good ones here in San Diego, right? And they actually said, he said, well, you know, most of these addicts don't want help anyway. That's what he said in a meeting with all the OBs and all the, and it was really, really, I guess it was just indicative of how far we have to go culturally still in this county. There's just still a lot of work to be done. Yeah. We also need to look for ways to make sure that patients that are getting their opioid use disorder managed by obstetricians, which is wonderful, that if they are not able to offer continuity care there, that they're properly linked to the community clinics, the opioid treatment programs or narcotic treatment programs that will be able to do so. And that's really important, right? A few years ago, most of the FQHCs, or the federally qualified health centers, a lot of them were referring any pregnant patient with opioid use disorder that was stable on buprenorphine, they were getting referred to UCSD. And there are obstetricians that do medications for opioid use disorder in UCSD, but the substance use disorder program at UCSD does not take Medicaid. So there were women that if they did not continue to go back time and time again to their obstetrician for the medications, would be lost to care. And so, I think that's improved, but it's still an area that we need to make sure women are not getting dropped from their care after after going through the initial postpartum services. And then changing the lens of stigma. So really just helping at any corner when you're talking to other folks in the community, changing this lens of, oh, we're protecting the baby from the parent, right? Because this is based on like addicts are bad and they don't change, and it's really, really, really just wrong. And so we need to help folks change their mentality and understand that if you have a healthy parent, you're going to have a healthy baby or safe baby. And we really just need to focus on being able to understand that this is true. And also addressing the myth that people don't change. Also addressing the myth that if someone is using substances, and maybe a non-pregnant person, we want to keep them, I mean, and a pregnant nurse, we want to keep them safe. We want to keep them from having an overdose, right? So really, really emphasizing access to harm reduction. And again, another area that San Diego County has come a really long way. And yeah. And then another point is just encouraging the hiring of staff that have diverse backgrounds. So I think if we hire folks that have diverse backgrounds and just with life experience, there tends to be an inherent compassion and understanding that that people have their various struggles, and it doesn't mean they're a bad person. Okay, just a couple more slides. So the last area that I was going to focus on was criminal justice and CWS. So engagement in these services can increase engagement via mandate. And the general hope is that this external motivation will turn into internal motivation through the treatment process that they're being asked to participate in. The issue is that these systems have different motivations and structures that are not inherently based on evidence-based medical practice or outcomes data for substance use disorder treatment. So it's just different priorities, right? So what that means is we really need to work together because we all have the same priority of healthy families, safe community, and wellness. That we have that goal in common. So it's just, making sure that we can understand the different information we have of how to get there. There definitely needs to be more collaboration, and this is an area we've come a long way. And again, I want to really shout out. I'm not from San Diego, right? So I've been able to see the growth as kind of I still feel a little bit like an outsider, and so I've seen the growth that's happened since I moved to the area in 2015. But we need to have more collaboration with specialty sub service providers. So if someone is out there, they're interfacing with women with substance use disorder all the time, right? In criminal justice CWS. So I really encourage folks to find their people, whether it's a navigator, a substance use disorder counselor, a medical provider, but an expert, that's somebody that works in substance use disorder, and build those connections and seek that information and those resources. This will lead to smoother transitions in care. So an example would be a jail linking people to resources upon release. Now people are getting started on buprenorphine in jails and prisons. Oh my God, it is wonderful. It is so great. And so now we're just working on smoothing out that transition, right? Getting folks to a federally qualified health center or an OTP, which is an opioid treatment program, or narcotic treatment program, or if they want further treatment, or even just giving them harm reduction resources, right? Making sure they're getting linked to what they need upon release. And then another example of that would be CWS being able to link new mothers directly to SUD services. And this does happen, but it doesn't happen all the time. And then another plug for more training to address stigma and cultural myths. And I say the word training, but also you know, there is just life training that people can have. And I love, like, I love those hires when you hire someone and they don't, you know, they could sit through some trauma-informed training, which is really, really important. But there's just an inherent ability to have a more nuanced understanding of people living with substance use disorder through whatever life experience they've actually had. So in terms of conclusions and future directions, I do want to say, you know, the positives, we've come so far. We have wonderful, wonderful perinatal services. We have, you know, 3 residential programs that take women with children. We have lots of outpatients. I was going to name them all off, but I don't think I have time. Uh, and I mentioned that we've come a long way with our drug medical services, with our federally qualified health centers, with our OTPs. We've come a long way with the corrections facilities offering treatment for opioid use disorder via buprenorphine in jails and prisons. So I really want to commend the work that everybody's done out there in the community because it's made a difference. I see patients now where they're like, there's so many options. Where am I going to go for my buprenorphine? Like, right? We're like offering pretty low barrier care. We get people into our clinic very quickly for buprenorphine. And the beautiful thing is we've seen so many other people doing this now too, that it's like, it's great. It's like people have multiple options, which I really want to commend the community on. There is more work to be done in changing culture and reducing stigma, specifically when it comes to women and specifically when it comes to women that are pregnant. And there are some service gaps that need to be filled, as I mentioned, the housing, childcare, education, jobs training, and improved collaboration can actually increase access to the services we already have in existence. So the examples I already gave of basically just linking criminal justice, CWS, obstetrics, labor and delivery to specialty SUD providers and experts in the community. And then considering hiring staff that are dedicated to interfacing with other organizations. So we have someone like this at San Ysidro Health, and she is so important. She's someone that is constantly calling over to detox or calling over to the ER, and we get direct to the bridge patients that come in there, you know, can then come to us. And it's really, really, really important to have somebody like that. It could be a social worker, a counselor. It really just needs to be somebody that knows the services, not somebody that's going to hand a piece of paper with a bunch of numbers, but somebody that's called every single one of those numbers themselves and knows exactly who's on the other line. And then finally, just want to say that, you know, Amanda's story represents common struggles. But we've made a lot of strides and we'll continue to make more. And so I think it's really important just to remember the patients, that the people whose lives are directly impacted by the services we provide and any improvements we make to them. I am including just some resources. So our access and crisis line, drug medical, and then harm reduction. And on the right, this is the pamphlet for some of the services for women and women with children in San Diego. That's it.